Dr. Henry Nasrallah from the University of Cincinnati College of Medicine, and Editor-in-Chief of Current Psychiatry. I'm very pleased to have with us today a very distinguished guest, a nationally recognized psychiatrist, speaker, educator, researcher, Dr. Glen Gabbard, whom we will be interviewing for the next 30 minutes or so. With me is also Dr. Pierce Johnston, who's on the faculty in the Department of Psychiatry here at the University of Cincinnati and Director of Medical Student Education. So Dr. Gabbard, I want to welcome you again and thank you for agreeing to this interview. It's a pleasure to host you today at the University of Cincinnati. Why don't we start out by finding out from you, what do you think of the current state of psychiatry in the United States today?
Well, Henry, it's a complex question. Thanks for inviting me here to discuss it with you. I think that psychiatry has always been something of a beleaguered specialty in medicine. And we continue to be beleaguered in the sense that economic forces draw us away from what is our unique niche, which is the biopsychosocial expert.
Exactly.
And many residents are recruited into situations where they're asked to see patients for 10 minutes, like a general practitioner, only do med checks without really getting into anything about the patient's psychosocial existence. And so we have to advocate for ourselves and fight for a broader based voice within medicine and within healthcare in general.
I agree. In fact, that's what many medical students tell me. They choose psychiatry because they felt we can spend more time with the patient than primary care or other specialties, and to take it away from them is not good. You're right.
And you know, the extraordinary advances in neuroscience also illuminate a lot about unconscious mental functioning,
Yes.
about the role of environment and genetics and development, you know. And so in many ways the psychosocial aspect is illuminated by neuroscience. They're not inherently antagonistic to one another.
No, the interaction, the gene environment interaction is a hot issue now in psychiatry.
Absolutely.
Good.
Go ahead, Pierce.
What's, in your opinion, the value of a psychiatry residency with a thorough training in psychotherapy and its principles?
Well, I would say, Pierce, that with every patient you see, you're using psychotherapeutic principles. That there is no interaction with the patient within the field of psychiatry where you're not worried about such things as a therapeutic alliance, for example, the role that transference or countertransference might play. And you're always trying to understand the person's psychological reasons for being there in addition to the neurobiological, so that we can't really separate in a reductionistic way teaching only neuroscience or only psychotherapy, because the two are going to work together with most patients.
Absolutely. Now, Glenn, you're a world expert in borderline personality, and you've made huge contributions, written many books about psychotherapy, borderline personality, and other topics. What is, if you could give our viewers just a quick, brief update, like what is our latest understanding of borderline personality?
Well, let me start historically, Henry, in that when I started out in the field, did my residency in the 70s, the borderline personality disorder was considered kind of like a chronic mental illness that wasn't going to change much. There was an expression used very frequently in the literature: they are stably unstable and will never change, basically.
Many people still feel that way.
I know. Now, I think one of the most encouraging things is that follow-up studies, which have been done now at McLean, and the collaborative longitudinal study that Skodal and others were involved in New York, have shown these patients get better. So this is a disorder that you now can tell patients and families is likely to improve with appropriate psychotherapy and medication, and that it's no longer a hopeless chronic condition. Now, it doesn't mean that everything is just fine. I mean, we don't usually speak of cure in psychiatry,
Yeah.
but that's true of most of medicine, except maybe infectious disease. Most of what we do is helping, is palliative, and somehow trying to make people a little better. But I think we have real optimism in the way that we approach this with families nowadays.
Right.
So we have, you know, NAMI was very important in leading the way, but now there is a group out of Boston that's in New England that's trying to develop a support group for families around, it's a whole organization called TARA, which helps families know what they can do or not do, that helps the family member who's borderline. And we have 7 empirically validated psychotherapies that have been shown in randomized controlled trials to improve patients with borderline
Can you
personality
mention some of them
disorder.
for our viewers?
Of course.
And the ones you use as well.
The transference-focused therapy of Otto Kernberg, Marshall Linehan's dialectical behavior therapy. Then there's a schema-focused therapy that's popular in Europe. And then we have mentalization-based therapy that Fonagy and Bateman developed. And then there's also a kind of what's called STEP, which is a combination of group and individual cognitive techniques. So that when you think about it,
We have many tools.
there are many tools and no reason for despair and thinking this person's just going to continue to be suicidal or end as a suicide. The other thing I want to mention, Emily, is in the follow-up study that Zanarini did on McLean, even in patients who are not in treatment, many of them get better.
Naturalistically?
Naturalistically. And, you know, to say it's stably unstable is a misnomer, because many of them get better, and for sometimes reasons that aren't clear. It may be that a certain kind of stable relationship they get into might cause improvements. They may learn something from negative experiences. So we often are a bit arrogant thinking that it's only our treatment that helps people. But we don't really know how people change. We think we do.
Yeah. Is there also an effect of as aging, as they get older, tincture of time also reduces their symptom severity? And
Yes. Now that's been that goes way back to the 60s with the Washington University people with the antisocial personality, thinking there's a burnout phenomenon.
Yeah.
Some of that is thought to be biological in terms of brain changes over time. Now, I think that's generally true of borderline personality disorder. There were retrospective follow-up studies that were done in places like Chestnut Lodge and in New York at PI, where they found that if you look at borderline patients in their 30s and 40s, they're quite a bit better than they are in their 20s, even though some of them weren't necessarily getting ongoing treatment. Now, on the other hand, you will see some elderly residents of nursing homes who look like they have a lot of borderline features. It's not true in every case.
You still have some.
Yeah, and there's the old saying, you know, that as somebody is dementing, their personality gets even more exacerbated.
Disinhibited.
Yes,
because
more like they always were.
Frontal lobe gets weaker,
That's
so
right.
all the attributes show up.
So
thank you for this summary.
Yeah.
And the last question about the borderline. Do you know of studies that compared, say, CBT, cognitive behavioral therapy, with psychodynamic psychotherapy? Are they, you think, similarly effective?
Well, there's one study that used schema-focused therapy, which is derived from CBT, and compared it to the Kernberg transference-focused therapy. This was in Europe, and the schema-focused therapy appeared to do a little better than the transference-focused therapy, but some of the trainers in the transference-focused therapy felt like there was not adherence to the manual and that it wasn't truly measuring the difference. So it's controversial, but it was published in the archives.
And maybe they work on different symptoms. I wonder if the psychodynamics and cognitive, because they have so many symptoms in this illness.
Yes, and one of the strategies you have to think about as a therapist is where do you devote your energies, because there are such a broad range of symptoms to look
You have
at.
to prioritize.
Yeah.